Good morning, everybody. Okay, my task is to talk this morning about transrectal ultrasound for rectal cancer staging, and in comparison or in competition with MRI, and this is really a competition between two champions. So, few words about colorectal cancer. We all know that it is a common and lethal disease, and more than 140,000 people will be diagnosed from this disease this year in the United States. More than 40,000 of them will be diagnosed as suffering from rectal cancer. The good news, however, are the progressive declining in mortality since 1990, and the rate of declination is about 3% for a year. Well, local regional staging for rectal cancer is important for the following reason: to select the surgical approach, to identify those patients who are candidates for neoadjuvant therapy before surgery, and to assess or estimate the prognosis. Neoadjuvant therapy is generally considered for T3/4 tumors, for node-positive T1/2. For distal rectal tumor, those are located in the 5 last centimeters in order to downregulate the tumor and to make the tumor amenable to abdominal perineal resection, and also, as Kobe stressed, tumor that appear to invade or in close proximity to the mesorectal fascia. However, the only definitive indication for neoadjuvant chemotherapy supported by the result of randomized trials is the presence of T3 or T4 rectal cancer, and this is stressed further on by a recent publication from a vast German study. And estimation of 5-year survival, it is also very important. Here we can see that for T1 tumor, the 5-year survival are around 74%, and for T4 tumor, less than 6%, and all the other stagings are in between. Now, TRUS, transrectal ultrasound. We can do it with several instruments: rigid instrument, flexible fiber optic echo endoscope, which is mainly the electronic with this thin instrument. We can transverse it into stenotic tumors, and it can be inserted up to 30 centimeters to assess the iliac adenopathy. And then we can use a linear scaling echo endoscope. Then we can take by this instrument fine needle aspiration. We can start with one instrument, continue with another, and finish with the third one. Now, here we have the high resolution 3D rigid echo or TRUS. High resolution, we mean that it can do 300 transaxial images over a distance of 60 millimeters, which means that the spacing between two adjacent images is 0.3 millimeters. Here we can appreciate the image and what we mean for high resolution, the different layers of the rectal wall, and a T3 tumor. And here another example of what we call high definition and T3 tumor. And this is the electronic radial echo endoscope. The thin one can easily pass up to 30 centimeters. And here we have the linear with a needle that can come from here. We will see it. Here is a needle, and that we can take a biopsies FNA with this needle. Now I want to show you a result of meta-analysis of 90 articles comparing the staging accuracy of MRI, TRUS, and CT to histopathologic findings, and the results were: for muscularis propria invasion, TRUS and MRI had similar sensitivity. Specificity of TRUS was significantly higher, 86% versus 69%. And for T3 disease, the sensitivity of TRUS was significantly higher than either MRI or CT, and they were comparable for T4 disease. All of them were comparable. So the author concluded that TRUS was the most accurate method to determine local tumor staging. Here is another meta-analysis of 42 studies, estimates the sensitivity and specificity of TRUS for determining T stages. and we see that either for T1, T2, T3, and T4, we had an excellent sensitivity and specificity, and the author suggested the routine use of preoperative truth in the evaluation of rectal cancer because of its excellent staging, provided that a competent endosonography is available. It's somewhat operator dependent. Here is another study, assessment of clinical impact of truth plus FNA on rectal cancer. And the aim of the study was to assess the impact of truth plus FNA by comparison the clinical outcome as recurrence in the era before and after the introduction of truth. And these two groups of patients were involved. In the control group that didn't pass through, 68 patients, 73 in the truth group. And the result was that Cox proportional hazard demonstrated truth FNA was superior. It was associated with reduced tumor recurrence risk. Hazard ratio was 0.72. Kobe talks a lot about circumferential radial margin, and this is a very important issue. And I agree with him. The preoperative identification of invasion of the mesorectal fascia is a crucial factor in preventing pelvic recurrence, and MRI considered an excellent instrument to identify the mesorectum and the penetration, and it considered better than truth. However, it was now in the era of high definition truth, this assumption may be challenged. And I want to show you just a recently published article about the accuracy of truth for measurement of the closest predicted radial mesorectal margin for rectal cancer. And the objective were to assess truth identification of mesorectal margin and the measurement of the closest predicted radial tumor mesorectal margins. And truth and MRI were compared in patients for this question, and 52 patients were studied, and it was found a good correlation. MRI and truth determination of margin involvement agreed in 81% of cases. And the conclusion was that truth had substantial agreement with MRI to measure the closest predicted radial tumor mesorectal margin. Now I want to show you a few figures from this study. Usually it was very difficult with a usual truth to assess the mesorectum, mainly the radial and posterior. However, this is a male rectum, and it was possible to see, not very well, but it was possible, and it's with experience it's become even easier to assess the mesorectum. And here we see the female rectum and the mesorectum, and now it is possible, and it is improving the assessment of the fascia. And what about the restaging after preoperative radiochemotherapy? So this article dealing with it, and it's compared CT, MRI, and truth after preoperative chemoradiation with pathologic staging of the operative specimen. 37 patients were studied by these three methods. They underwent neoadjuvant therapy, restaging, and surgery. And here are the results. Sensitivity, T3 sensitivity was superior for truth comparing to MRI. It was comparable for T2. Specificity for T3 was comparable, and the specificity for T2 staging was superior for truth. And moreover, the author found that truth was statistically significant, more accurate than CT and MRI in negative lymph node diagnosis. So the conclusion was that truth was the most accurate method for restaging. What about follow-up after resection? Here we have only comparison to CT, and truth was found to be superior for assessing recurrence after resection. The sensitivity of truth for detecting recurrence was higher in two studies, about 100% in both studies compared to 82-85% for CT, and the authors use the possibility to do FNA to increase their possibilities. What about cost effectiveness of truth? So a decision analysis model was found, and they compared the cost effectiveness of 3 staging strategies in the evaluation of proximal rectal cancer: abdominal and pelvic CT versus abdominal CT plus truth versus abdominal CT plus pelvic magnetic resonance, and the results were that abdominal CT plus truth was the most cost-effective approach. What about learning proof? You know, it was said a lot that there is a long learning curve, and it's an operator dependent, but in this study it was shown that staging accuracy improved very quickly from 58% for the initial 12 studies to 88% for the remaining 24 examination. So here I have a few conclusion remarks from the literature. American Joint Committee statements of cancer said that the 2 imaging modalities that are most useful for local regional tumor are truth and MRI. Both are more accurate than axial CT for assessing the depth of tumor invasion, nodal staging, and predicting the CRM. And here a citation from Cancer recently: at present, truth and or high-resolution MRI are acceptable radiographic method to determine preoperative local tumor stage. Local expertise may influence the choice of modality, and the information obtained with truth and MRIs is often complementary. And up to date, recently, the choice of imaging modality by a unit is influenced by availability, operator preference, and the unit philosophy regarding which staging information is necessary on which to base neoadjuvant treatment decision. My conclusion: truth is straightforward with relatively short learning curve. Combined with CT for distant metastasis, it is the most cost-effective staging modality. FNA sampling adds a lot, and it offers advantage in classifying early tumor, and recent study showed that truth has substantial agreement with MRI to measure the radial mesorectal margins. So, as I said in the beginning, this is a competition between 2 champions. Each can win in different situations, and when they are working, collaborating together, they can make a great team. Thank you.